There we go. Okay, so I would like to introduce you to our guest speaker, Dr. John Marcapondo. Dr. John Marcapondo is a medical health officer for Saskatchewan Health Authority, Saskatoon, and has several years of experience in public health. He received his master's training in public health from Atlanta's Emory University, worked at the Centers for Disease Control and Prevention, CDC, in Atlanta, following a clinical career in Kenya as a medical doctor, where he also served as a district medical health officer in the city of Mombasa. Dr. Apondo has worked in Saskatchewan and in the last 17 years, mainly in public health and preventative medicine in various roles. Please help me welcome Dr. Apondo. Dr. Apondo?
Yes, thank you, Wendy and Kathleen, and good morning, everyone. Some of you I may have met before, and we're certainly in COVID times, so we're now meeting over Zoom. I'm somewhat experienced in online kind of presentations, but you always learn as you go. Zoom is a pretty new technology, so I'm really thankful and welcome. So today, I have been invited by the Saskatchewan chapter of the Canadian Association for Retired Persons to talk to you about adult immunization, but not the whole segment. You know, there are some vaccines that are needed for adults, but three particular vaccines, and I will explain that as we get into the agenda. But I also want to give a context of what the diseases are. And what we'll first start off with is respiratory diseases and all. And respiratory diseases, I think seniors have actually been more astutely aware than the rest of us, as COVID will show. So let me just launch in. I'm going to be a little bit fast, but if you can type your messages in, and then Wendy and Kathy can try and get me the questions, and I'll do my best to try and answer. So here we go. So even though we're in the middle of COVID, let's not forget that old threats like influenza and pneumococcal disease still exist. So, that's going to be part of my discussion with you today. And COVID is important to keep in mind because, each time we've seen an increasing wave of COVID, there's been a new variant strain that's been introduced. What we're experiencing in Saskatchewan at the moment is the Delta strain, and the Delta strain is the most infectious strain of COVID so far. Essentially, we're really back to square one. You need to keep an ear out for invitations for the COVID third booster. If you haven't received your vaccine, get your 2 doses, but the third booster is coming. Especially for those who are immune compromised, which is a category of our group that we really have to get good consideration about. And you'll hear that theme repeat itself. Those of us who have underlying chronic medical conditions, we are at increased risk or elevated risk for not just influenza or pneumococcal disease, but even shingles, which are the 3 diseases that we're going to be talking about. So in this age of COVID, the main thing is we need to remain adaptable and we need to be vigilant to move ahead. What's happening as we come into November, December, or October, November, December, we're really entering flu season territory. Traditionally in Saskatchewan, flu vaccines are offered in October, usually from the second Tuesday of October onwards, I think just after Thanksgiving. So this is coming. Please get your flu shot. So the vaccines we want to talk about, or the diseases, we really want to talk a little bit about influenza and the high-dose flu, the pneumococcal disease, and we will have a discussion of the polysaccharide, the 23-valent vaccine, and the pneumo 13 or the Prevnar formulation of the pneumococcal vaccine. And then for the varicella, we'll just talk about Shingrix. I just thought I would put down Zostavax, which is an earlier formulation of the varicella vaccine, which is a live attenuated herpes zoster preparation, is not available in Canada anymore. So the main prevention of varicella or shingles is Shingrix vaccine. I do want to just visit because I'm going to be talking quite a few times, NACI, which is this is the National Advisory Committee on Immunization in Canada. And it's probably important for you to understand who NACI is and what they do. There are a couple of other regulatory and advisory bodies that are available globally, and we do refer to them in this presentation. That's the World Health Organization, or WHO. So I'm just explaining what these acronyms are. The World Health Organization, and we also have the Centers for Disease Control and Prevention, and the equivalent of NACI in the United States. So the CDC is a global organization, but based in the US. It's part of the US federal government. Their equivalent of NACI is the Advisory Committee on Immunization Practice that is also included in this slide there. So NACI, or the National Advisory Committee on Immunization, I'm wondering if during COVID you may have heard that, but this is the committee of national experts in Canada, both in medicine and public health, that provide advice to federal bodies and to the country regarding the medical and scientific evidence, particularly around vaccines. NACI makes recommendation on the use of vaccines in Canada, and we all really wait for new vaccines in particular that have been approved by Health Canada, which is the regulator that allows use of these new products in humans. And NACI actually makes the recommendation of which categories, which age groups based on the scientific data. NACI is quite a well-respected body that all their documents and their knowledge synthesis is usually published and is used in many places, in many kinds of forums to explain where we're at in Canada in terms of our vaccination program. So when we really talk about WHO and Public Health Agency of Canada, for example, both of these big organizations have both concluded and made strong recommendations that the most effective way to prevent influenza and its complication is to get vaccinated. So that is just the theme from all the main regulators. It is important as we get into this presentation that when I talk about vaccines in Saskatchewan, a particular vaccine may be indicated. So it might fit the federal regulations that it's indicated for preventing this particular disease, and it may be in WHO and CDC and even Health Canada literature. It may be even recommended by the National Advisory Committee on Immunization, but the question of funding becomes a provincial issue because health is a provincial mandate. And whether a particular vaccine is funded or not is going to be part of our discussion today, because the three vaccines we've chosen, which is the high-dose flu, the Prevnar or pneumococcal conjugate vaccine, which has 13 different serotypes included, and the Shingrix vaccine, are not currently funded in the provincial drug formulary. It is allowed and it is funded, partially funded for some groups, but are not funded across the board for those over 65. And the marketing of vaccines is a different matter, which is really the work of the manufacturer. And there's lots of those of us who get US TV in the United States, there's a lot of advertising of particular vaccines and all, which doesn't happen in Canada. So you may actually encounter and see very strong and very compelling ad or marketing campaigns regarding these particular vaccines that are aged at our age group. So influenza, let's start with that. Flu is a very contagious respiratory disease, and influenza is very different from having a cold. During the fall and early winter, it's cold and flu season, and we really get confused because many people, they confuse the common cold with the influenza, but influenza is a very contagious respiratory disease, and it is usually very severe. The symptoms include fever, cough, sore throat, runny nose, and fatigue. And I do have a table that really compares the two, but transmission is usually by droplets. So if you're around someone who is coughing and sneezing and has the flu virus, they can actually transmit flu particles, which if they land on you because you're closer than 6 feet away from them, you can get infected. So this summary table really compares the symptoms of the cold, of the common cold and influenza. And just so that you know, as strong advocates for your own health, the common cold is mainly caused by rhinovirus and coronavirus, which is a cousin to the COVID-19 virus. So those are the top two causes of the common cold. And the common cold really presents with symptoms of stuffy, runny nose, maybe sore throat, fever, headache. Those are the usual presentations. The difference between that and the flu is if you look at the list for influenza, it has all those symptoms of a cold plus. Influenza, the symptoms of fever and all are usual. You're extremely fatigued, you're completely wiped out, and pneumonia and other complications as a result of getting flu is very, very common. So that is the difference between the two. And flu is a serious disease. I think this is not the group that would argue with this, but I know I do talk to a lot of people and they feel that the common cold is just something, a few days out and you'll recover, and don't realize that flu circulates seasonally. A lot of people who are not protected get infected. And if you get sick, this is the burden of illness. Hospitalization, if you are hospitalized, it's about 11 days of hospital stay. Some of that, if you have underlying medical conditions or you're unlucky to get into ICU, it's about 10 days of ICU, which is quite an important cost to the healthcare system, let alone the social costs to yourself and your family, because you're not available to socialize or do the other things you'd like to do, whether it's supporting your kids or your grandchildren or other things that you are in productive enterprise every day. So flu is an important disease for us who are over 65, partly because we tend to have certain factors that make us more susceptible to the effects of flu. Immunosenescence is a term that with aging, our immune system is not as strong as it is when we were sort of young, youth, or middle age. In fact, it's only when we're young when our immune system is at its prime. But as the older we get, our immune system begins to get older as well. And the older we get, certain conditions such as hypertension, cardiovascular disease, begin to show up as well. And not always is frailty associated with aging. There is healthy aging, but there's a higher proportion seen in older age groups. This makes us as a vulnerable population to getting infected with influenza, but not just influenza, but with the severe complications of increased hospitalization. A bout with flu can really impact our mobility and our autonomy. I know most seniors that I encounter in Saskatchewan are very fiercely independent. This is the generation of the Second World War. This is a strong generation. So losing their independence and autonomy is a really important loss. And ultimately, the risk of death and mortality is increased if you get a bout of influenza. And that's a very, very bad and an adverse outcome that we all want to avoid. As I'd earlier said, hospitalization as a result of aging and flu is actually quite a common pathway. And it's partly the normal, what you expect with aging. That's what makes us more susceptible. But if we end up being hospitalized because of a severe bout of flu, that change, that increased immobilization does bring in other risk factors to our life. Things can happen in the course of that illness that it's unfortunate that many seniors over 65, when they're discharged from a bout of hospitalization with flu, even though they're discharged to home care or they're discharged into a long-term care facility, which is really an outcome that we want to address, because influenza basically can produce significant long-lasting functional decline. And these are preventable facts that can be prevented by getting the right vaccine. That really helps. And if we have underlying chronic diseases, there's actual scientific data that your risk of being hospitalized if you get a bout of flu is 5 times greater if you have chronic heart disease or cardiovascular disease. For those with chronic lung diseases such as COPD, asthma, pulmonary hypertension, I'll just give a couple of common causes, that you're 12 times at risk of being admitted to hospital. These are common as we age, as we are over 65. If you have both, which is not an uncommon situation, then you're 20 times at risk of being hospitalized. There's a range of vaccines that are recommended for flu prevention in Canada. So this is the list. There's a live attenuated vaccine. The most common one is the inactivated 3-valent vaccine, which is the standard dose. There's a flu culture-based influenza vaccine, high-dose flu, and a particular flu formulation that has an adjuvant admitted. I know that's kind of a complicated thing, but it's compounded in a way that promotes the immune reaction to the flu vaccine. And it's, other than the live vaccine, the others are recommended for those over 65 and is available in Canada. So it's just good to see that list, and particularly our discussion will compare the high dose flu, the one in pink, versus the standard dose flu, which is the one in sort of, I'd say, I don't know if that's a teal color or turquoise color. So NACI has already made recommendations that high dose flu is preferred over the standard dose flu for addressing seasonal influenza. It gives better protection for those who are 65 years and older. However, in a time of crunch, if you show up for clinic and there's no other formulation available, it's preferred that you get any of the recommended vaccine for your age group that is available. But having said that, there's many studies in several places and in several settings. I'll just give a couple of examples. You know, the Veterans Affairs Administration in the United States, which is the largest sort of hospital or fully funded cohort for healthcare if you served in the US military. So the US military is quite a big operation. They have their own hospital system. They've used high-dose flu. We've gotten examples from previous influenza seasons, both in the United States and Canada. But it does show that the high-dose flu not only induced a higher antibody level when compared to the standard dose, but high-dose flu also provided 24% more protection or superior efficacy when compared to the high dose, to the standard dose. When we say 24% relatively improved coverage by the high dose flu, I think it's just best to give an actual example. If you consider 100 people or 100 cases of influenza, which might have developed in people who are over 65 if they had no vaccine, if they got the standard dose, it's estimated we could have prevented 30 of those 100 influenza cases by giving them the standard dose flu. What the high dose flu does, this is the 24% number, is in addition to the 30 that would have been prevented, it can prevent an additional 17. So 47 out of 100 cases of influenza in any given year for those over 65 would be prevented by just using the high dose flu formulation. So this is really important. Older adults do experience a high burden of influenza and are not as well protected by the standard dose as we've talked about. High dose influenza does provide superior protection for those who receive it compared to cohorts who have received the standard dose. And then the high dose flu is actually recommended by NACI as the preferred vaccine for those over 65. And based on data collected from many settings, this is expected to reduce the rate of hospitalization or hospital admission, which is important in terms of reducing hospital costs. This is a big cost to the publicly funded healthcare system, but we haven't even added in the social costs of our loved seniors being away and being away from us for the 10 or 11 days that they end up experiencing hospitalization. So, in summary, flu season is coming. We really want to be ready. It is an issue that, although we have both some seasons of influenza A and influenza B, I didn't go into a lot of the science, but influenza B in years where B dominates, or what happens in every season is once the influenza A has run its course, we see a small bump, usually between January and May, of influenza B. So the high dose flu formulation does contain 2 A's and 1 B and has been shown to be more protective with B. There is also preparations and work that's happening on getting a 4-valent flu vaccine that would have 2 A's and 2 B's. So that is something that I think we look forward to. But to meet the challenge of seasonal flu, which is really always with us, we really want to make sure that influenza vaccines are ready and evolve and are ready and are addressed to the right population so that we can protect our seniors. And there is NACI recommendation that, this will come up with pneumococcal disease, but for those who end up with influenza and are hospitalized, what usually follows is a pneumococcal illness. And this is a NACI recommendation regarding the Prevnar or the pneumococcal 13, which I'll talk to you about in more detail. I think the slide just got misplaced from the order, but flu is an important and is really sort of the most important infectious risk for people over 65. And I've gone through the NACI recommendations. Some of our slides seem to repeat themselves. High dose flu is available in various publicly funded programs in different provinces in the country. In Ontario, Alberta, and Prince Edward Island, all 65 plus are covered. In other provinces like Saskatchewan, we have a little bit of a mixed model or an in-between model where seniors 65 plus in long-term care and in personal care, so there's expanded access in terms of publicly funded. But for seniors who live in community, we still don't have them covered, which is an important point. And in some provinces, I think the rest of the provinces and territories in Canada, it's only long-term care coverage that is currently in place. So Saskatchewan is kind of in the middle compared to the other provinces. And you can get your flu vaccine in most pharmacies. In fact, this morning in the SHA, the discussions was in terms of booking and online booking. And I think most pharmacies and physicians' offices are gearing up. You can also get it from your local public health unit. Public health usually offers at the beginning of the flu season, like they did with COVID, sort of mass vaccination sites where they can deliver a large number of vaccines in a short period of time. And the program will start on October 12th this year. High dose flu, as I had said earlier, is provided in long-term care facilities in Saskatchewan and personal care home residents who are 65 years and older. So flu is important, and flu, like it's a viral disease and causes a lot of illness and death. However, a majority of those deaths are due to secondary pneumococcal infection, which is really the next vaccines I want to talk about. So in contrast to influenza, pneumonia is a bacteria, and the strep pneumonia is a gram-positive bacteria with many, many different serotypes. But it is one of the most common bacteria that is found when people are admitted to hospital with both, well, particularly with community-acquired pneumonia. When we look at these various settings of where patients have come from, outpatients, hospitalized, or in the ICU, these are the common causes of pneumonia that have been typed and isolated. And you can see strep pneumonia is at the top of the list in all settings. There are occasional situations you hear about, things like Legionellas or Mycoplasma. These do cause pneumonia and can cause hospitalization, but are not as common as pneumonia. So preventing the pneumococcal disease is really important, again, for those in our age group. And once again, this is the burden of illness caused by pneumococcal disease. So 32, depending on age, this is a very age dependent, 32% to 77% of patients with community-acquired pneumonia require hospitalization. So if you're a young person, it's about a third of them end up in the hospital. But for those of us who are over 65, more than half of us, if we do get pneumonia or community-acquired pneumonia, we will end up being hospitalized. And the hospitalization due to pneumococcal pneumonia is highest in that age group, and a high proportion. So more than 10% of the people who end up in hospital with pneumonia end up with a fatal outcome or die as a result of the pneumonia. It is a common cause of pneumonia, but it can also cause other serious diseases like meningitis or a blood infection that's known as bacteremia. As I've said, this is quite an important cause of death and mortality, particularly the older you get. There are other medical conditions that put you at high risk of having an invasive pneumococcal disease attack. And then those conditions like those who have what's known as a CSF leak. This is much more seen in younger age groups, that particularly those who need shots for managing conditions like hydrocephalus. But if you have neurologic conditions like Guillain-Barré syndrome or any kind of neurological condition that makes the coughing reflex difficult, that can make it difficult for you, and you puts you at risk of getting pneumococcal disease. There are other much more common situations like diabetes, chronic kidney disease, chronic liver disease, and lung disease like asthma. All those can lead to pneumococcal disease. And this is a summary of the NACI recommendation. So NACI, as I'd said earlier on, is an advisory body in the Public Health Agency of Canada. And NACI has recommended as a strong recommendation that all adults over 65 should get the pneumococcal polysaccharide vaccine, which has sort of a mixed efficacy in preventing pneumococcal disease in the older age groups. And but they also have made a recommendation regarding Prevnar. So Prevnar 13 and pneumococcal vaccine are both recommended, and there's a specific schedule. It is preferred if you haven't had any pneumococcal vaccine before, you get the Prevnar first, and then you get a booster with your pneumococcal 23. The Prevnar is not funded at the moment, but the pneumococcal 23 is funded. And the Saskatchewan Health Authority, I think the web address at the bottom is where you might find some written material that talks about pneumococcal disease and vaccines that prevent it. And it does discuss funded versus unfunded in terms of eligibility criteria. But observation based on looking at Saskatchewan data is there are large groups of patients who are eligible for pneumococcal vaccines who don't get it. I think they haven't received the message, or we really haven't done a good job in communicating why this is important. As I'd said, with pneumococcal vaccines, like the rest, there is different, there's the national recommendations, but whether it's funded or not is an important question. And for those of us who live in Saskatchewan, uh, pneumococcal vaccine, the pneumococcal conjugate vaccine is recommended and funded for those over 65, those who are residents of extended or long-term care or intermediate care facilities, and anyone with those medical risk conditions that I listed. So you can get the funded vaccine from any of your public health offices. As I had indicated earlier, I think I'm moving around a little bit too much in the slide. So part of the challenge, part of the challenge with the pneumococcal vaccines is the order and getting access to the Prevnar 13, which at the moment is not a funded vaccine and may not always be available in the pharmacies, but it is definitely available in your public health office. And I'll go really quickly cover the Shingrix vaccine and really talk quickly about shingles. I think many of us may know or may have heard about shingles, but may not make the association that shingles or herpes zoster, it is a skin rash, but it is the same virus that causes chickenpox. Most of us who end up developing a shingles rash or zoster, it's because we had chickenpox previously, or we had chickenpox in childhood, and maybe we remember, we don't remember, but that makes us at risk of getting shingles. And many of us born in Canada and have lived in Canada, 1 out of every 3 people is estimated will get shingles, but it's almost assumed that 90% of us have been exposed to chickenpox in the past. And the problem with shingles is the pain and the debilitation that can come with the rash, and particularly depending on where the shingles rash appears. If it usually covers particular areas of the body following a group of nerves that are related. So you can get shingles on the face and sort of a facial nerve one, which could cover the eye area, which is very serious because it can affect the eye, or the lower jaw and the cheeks, which could affect your facial nerve and cause what is known as ptosis and difficulty in speaking and sort of a little bit of a pulling and distortion of the face muscles. So shingles is a serious disease, and it can rarely also lead to pneumonia, hearing loss, blindness, or encephalitis and death. And as I said earlier, if you've had chickenpox, then you're at risk of getting shingles. And the lifetime risk increases the older you get. The most important age is, well, the starting age is at 50, but each decade after that, your risk of developing shingles gets higher and higher. Pain usually starts before the rash in most cases. And it starts with a little bit of an abnormal skin sensation, preceded by a rash, which is kind of like a blistery rash. It's sometimes a little bit watery. When it's still at that early pain stage, it's very difficult to decide whether, if it's only pain, is this cardiac pain, depending on where it is, or is this a gallbladder or another issue? But once the rash develops, it becomes quite clear that this is shingles. It's an experience of shingles. I think I have said this, and this is a little actual picture that I got from the internet, but it is showing a facial presentation of shingles that covers the forehead and the eye. So it is very risky. And part of the problem with shingles is, even if you recovered from the rash stage, you can develop a lot of pain afterwards in that area. And this pain is very debilitating. In that, it really is something that causes a lot of other symptoms of, depression, restlessness. This whole syndrome is known as post-herpetic neuralgia. And as I said, it can present with a variety of other symptoms, physical symptoms like fatigue, weight loss, physical inactivity, insomnia, which might be as a result of the psychological effects of anxiety, difficulty in concentration, depression, suicidal ideation. If the shingles presents in a very awkward place, it makes you socially withdraw and attending fewer social gathering, and it really interferes with a lot of activities for daily living because of the pain, dressing, bathing, eating, traveling, cooking, all those aspects of life get impacted with shingles. This is really the point I was trying to make. The risk factors for not just developing shingles, but developing the severe complications of the post-herpetic neuralgia. The risk is higher in women, it's greater. The dermatomes involved, those are the sections of nerves that supply various parts of the body. If it involves the eye or the facial muscles, it's really, really bad because it can cause other complications. It's not necessarily associated with being immune suppressed, but it does sometimes appear first when your body is under other stresses like illness. But for those who are less than 40 years, even if they've had chicken pox before, herpes zoster usually doesn't appear. But once you are over 50 years, the risk continues to grow, particularly high risk for those over 60 years of age. And with each incremental year after 60, there's an additional 12% increase in risk of developing shingles. And the fact that shingles happens after chickenpox, in terms of administration, the public health system does not have to make sure that they look for blood evidence that you've had chickenpox before. It's so common in our setting that shingles can just be given to virtually everyone. And determining that history, it's kind of an unnecessary, and it does cause just delays in getting the vaccine. It's important for us as over 65, or once we hit 60 and older, to talk to our health professionals about getting this dose. It isn't a single dose. I think this is a little bit old. It's a 2-dose formulation for the Shingrix vaccine, but it can reduce your risk of getting shingles. If you have chronic medical conditions, you can still get your shingles vaccine. And the trials have shown that those who receive the shingles vaccine, it cuts their risk by at least half, if not more. So it is important to talk to your health professional if you're interested and if you really want to pursue this, because at the moment, this is not funded. This vaccine has gone through all the regulatory bodies. The side effects of the vaccine itself are usually mild. It's like local pain, but it is safe in majority of people, other than if you are pregnant. Pregnancy is the only main contraindication. So in summary, the Shingrix vaccine in Saskatchewan is recommended for individuals who are greater than 50 years of age who have no contraindications. If you received the live Zostavax or had a previous episode, you should be given the Shingrix vaccine 1 year after that live vaccine. It can be considered for those who are immune compromised, and this is really why you need to talk to your physician. It's given intramuscularly as a 2-dose schedule, and it's given, and there's 2 months or 6 months after the first dose is usually the spacing. It's available in most pharmacies in Saskatchewan or in some physicians' offices and nurse practitioners, and some public health offices that do offer sales clinic do carry the Shingrix vaccine. I just thought this was a little bit of information that folks might find useful, comparing the performance of the Shingrix vaccine and the Zostavax, which are produced by two different companies. The Shingrix vaccine has performed better. It's a 2-dose injection, while the live attenuated vaccine is a single dose, but it isn't available in Canada. But this is the difference between the two. And there's an 88% effectiveness against developing the severe complication of post-operatic neuralgia with Shingrix versus 70%. So there's a slight difference between the two. I think in summary, as I'm heading to a close, immunization and getting vaccines are really important. This is one of the greatest achievements of medicine. This has not just improved the lives of every Canadian and those of us who live in Saskatchewan, but this has improved the lives of everyone. In fact, childhood immunization has been thought to be the most important intervention that has reduced childhood mortality globally all over the world. However, although we have made recommendations for adult vaccines, and there's a range of vaccines that is compared in terms of the Canadian target for those 18 to 64, which is on the left, and those greater than 65, we really, in no age group have we met the Canadian target. Looking at those of us over 65, which is the topic of today, even influenza, which is publicly funded, we haven't hit our targets. Pneumococcal vaccine is only about 37%, and there is still some work. But there are other adult vaccines, which was not part of this presentation, but are publicly funded, getting your vaccine for pertussis, protection, and tetanus. Tetanus needs to be renewed every 10 years. So we're really behind in all our Canadian targets. So this is really, as we advocate for some of those non-funded vaccines that we're interested in, I think the other group that we need to talk to is our healthcare providers. Because our healthcare providers, as seniors, we are in our doctor's offices many, many, many times. And we really feel, this is the same message I give to healthcare providers, that please talk to your seniors over 65, particularly in this COVID environment. We're really trying to make sure seniors, particularly 80 years plus, who haven't received their COVID vaccine, if they have an episode of COVID, the chances and the likelihood of landing in hospital are very high, particularly with this Delta strain. So if you are seeing your doctor for anything, hypertension, kidney disease, or COPD, they should talk to you about that. So I will end here because I know we wanted to have a little bit more of an interaction and an opportunity for questions. So I will stop for now. Thank you. Back to you, Wendy and Kathleen, sorry.
Okay. I will start off with the first question, and feel free to say that you're not prepared to answer this one. Do you recommend the COVID-19 booster vaccine?
So COVID, I'm going to give a little bit of context, and the opinions I will express are initially my own as an informed person. But yeah, so COVID is a serious risk for those of us the older we get. So seniors have done really well, and we have 80 to 90% coverage with 2 doses. What we've seen over the course of COVID, most of us as seniors, we received our COVID vaccine January, February, March, maybe April of this year. Actually, there's a little bit of waning. So I'm going to use our long-term care facilities as an example. From April to about August, things were very quiet in our long-term care and personal care homes, but we've really seen another round of pickup of outbreaks of COVID-19. They're not as severe in presentation. So this is really the latest news. It's not published yet. They're not as severe. But I really think getting your 3rd booster, if it is recommended, and I understand the province is going to be sending invitation letters for those of us who have chronic underlying medical illness and our seniors, I would take it. I would recommend you get your booster dose.
Excellent. Wendy, do you have a question? Or do you want me to keep going here? I'll keep going. Why is the Saskatchewan government, why is it the Saskatchewan government seems to be resistant to supporting funding high dose flu vaccine for older adults?
So I have to make a little bit of a disclaimer. I am not part of the government of Saskatchewan, and I'm not 100% privy to how the decisions are made. But healthcare costs are things that I know the government is always thinking about. I sometimes wonder if this data, in terms of preventing illness in over 65 and reducing the risk of hospitalization, particularly at a time like now, where our hospital and our acute care system are really not just over capacity, we've really gone into the next stage of being overwhelmed. They are very, very busy, and the beds are full of COVID patients. I think, it is strategic not to wait until COVID is done. This is the time I would advocate very strongly for the minister, because this would be, whichever way he interprets this, if this is COVID prevention to give him more room to address COVID in the hospital, well and good. But I really believe even the science of giving good coverage to seniors over 65 is solid and is compelling. It is more expensive, but it is actually cost effective in terms of reduction, that I would use that opportunity now. But I know I haven't really answered your question as to why, but I wonder if the why lies somewhere in that range of answers.
Okay. I had an aside to that. It is difficult to even access high dose flu vaccine in Saskatchewan, even if you're willing to pay for it yourself. Last year, what we had was people who were willing to pay the $80 or whatever it was for the high dose flu vaccine. The pharmacies were unable to get their hands on the vaccine. I can tell you that Sanofi has let me know that there will be ample supply of high dose flu vaccine available this year to people in Saskatchewan. When I asked the question, would that be enough for everyone who wants it? They kind of hedged on that one. What we do know is that there will be a large supply of it. Whether it will be enough for everyone who is willing to put the money down to get the high dose flu, that we're not certain of. So I just sort of answered that question for you.
No, thank you. But yeah, no, I do hear that, and I know, accessing it through the private market is sometimes hit and miss. But for present, that's what it is. But Sanofi, who is the main manufacturer of high dose flu, have indicated that they are going to try and address that for this season, because they do understand we want to do everything, including get our flu vaccine, to prevent needing to go to the hospital at this time where things are really not great.
Okay, Adeline writes, how often should seniors get the pneumonia vaccine?
So the Saskatchewan recommendation is, if you're over 65, you should get a single dose of the pneumococcal 23. So this is the polysaccharide vaccine that is publicly funded. The Prevnar 13, which is relatively new, is recommended by NACI. So if I give you the best case scenario, would be what is recommended by the advisory committee of experts is get one dose of Prevnar first, wait for a year and get one dose of pneumococcal 23. That offers the best protection. Getting more than a single dose of both of this doesn't give any additional protection.
Excellent. Okay, Brian writes, if I had shingles as a young adult, do I need to get the shingles vaccine?
It's rare, and but it does happen. Some people do have a second and a third episode of shingles. I think if you reach the 60 plus, it might be advisable to get that one-time shingles dose, just to protect for particularly developing the pain and the painful syndrome after getting shingles. So it is still recommended if you've had shingles, but similar to the previous question, if you had an experience of shingles, you need to wait for at least a year before you get the shingles vaccine.
All right. You talked about the targets for vaccination, and our targets are really, we're not getting anywhere close to ideal targets on meeting those targets of immunization. What is your recommendation for people going forward with regards to this? How can we bring this up and ensure that our older adults are more adequately protected?
To tell you the truth, as much as I've known this, but I think having the data is useful. This is one of those slides that I wonder if this is additional ammunition as we talk to government, as we talk to ministers and ministers for health. These targets are actually set by government and government agencies. And particularly for the funded programs, it's not just a matter of setting the targets and then letting the vaccine loose. You need to promote how you're going to deliver. You need to prepare the vehicle for getting this into the arms that need to get it. I wonder if this is a message that as we talk, particularly to the Minister for Health, because I feel the gap here. I'm gonna let me put on my individual hat as a physician. There's a lot of targeted program to support school age and infant program, but the adult programs are not structured in any way. It's kind of loose. I put in one slide there where I was advocating to physicians, but that's not a program. Physicians do get paid if they do it. But I really wonder if this is the time for government to step in, especially if people are interested in vaccines. If government has set these targets, I wonder if this is more ammunition that we can use as we talk to the minister. These are funded programs, so they need to be developed or delivered in a way that the structure and the support and seniors will get them when they present for care.
Okay, I have another question here. What is the cost of these vaccines? Do you have that information? I have ballpark figures of my own, but
so I did check with the Saskatoon clinic, and they gave me some prices. I think they don't always carry high dose flu, so the $80 mark I think is accurate. For the Prevnar 13, they tell me it's $156. And for the Shingrix vaccine, it's $175 per dose, and you need 2 doses.
wow, that's expensive.
It is expensive. And I think government in a way has not really explained how much vaccines actually cost. But vaccines are an expensive enterprise. But I feel when they offer these vaccines strategically, they do recoup those costs in terms of preventing complications and preventing hospitalization, which is where we spend a lot of money as a society and as a government. So there's a potential win for them, but it isn't a very cheap kind of alternative. These are pretty expensive vaccines.
Yeah, we've got lots of statistics that bear that out. That it is prevention is a lot less costly than the health outcomes if from not being vaccinated, and the hospitalization of people, and the potential for death in some cases as well. Okay.
We have another question here, Dr. Opondo. Uh, This question is, had 2 AstraZeneca shots, now getting Pfizer for traveling. What effects on body may occur, if any, and any studies to that effect?
Yes, so for those who may not know, the AstraZeneca vaccine is a good vaccine and has been studied. It was manufactured by, the company is actually called AstraZeneca, and it's been manufactured in various places in the world. So getting 2 doses of the AstraZeneca vaccine should provide protection for COVID to the range of about 80–90%. And this is one of the vaccines that Canada went with. Some countries, such as the United States, didn't use, but they used a similar equivalent, which is the Johnson & Johnson vaccine, which is a single dose. So my response is getting the Pfizer vaccine on top of the AstraZeneca vaccine is useful for reasons of travel, especially if you're traveling to the United States. I think that's the country that has given us the most trouble. But I think for travel purposes, you need to get 2 of the same vaccine. So because in the US, they use Pfizer, they use Moderna, and they use Johnson & Johnson, you need 2 if you're going to get Pfizer or Moderna. But if you choose for Johnson & Johnson, it's just a single dose. So I think for reason of travel, and if you end up going to the United States frequently, like I know some of our snowbirds do, yep, that might be the option that you choose. There's no risk. I think that might be embedded in your question, that is it risky adding this additional vaccine? There's no known risk. For younger people, they did see a couple of potential complications with sort of myocarditis in young people. But AstraZeneca, the risk again is in a younger demographic if they would have developed sort of some clotting disorder or cerebrovascular disease. But adding Pfizer on top of AstraZeneca as a mixed combination, there isn't any data that has found that to be dangerous. It is safe, and for now, that is recommended because it's very difficult to work your way out of the US regulations. They require the type of vaccines that they have approved in their country.
Thank you. One more, actually, we have a couple more. Vaccines we received as children, should we be getting boosters on some of those, I believe is the question.
Yeah, so vaccines, I'm going to give a little bit of a broad answer. Vaccines are very good, but vaccines have a range of efficacy or how they work. So there's some of those childhood vaccines that are very, very good. You know, for example, if you received 2 doses of the measles, mumps, rubella, chickenpox vaccine as a child, that does not need to be repeated at all. That is a very, very effective and efficacious vaccine. It's almost a gold standard. It's like the hepatitis A vaccine. You get it once and you're done. But there are some vaccines and diseases that over time, the way they work sort of wane. So tetanus is one example, and pertussis, you need a booster. So tetanus, you need to be boosted every 10 years. Pertussis, you need a 1 adult booster. The pneumococcal vaccine is not, it is offered in childhood in Canada, but as you turn 65, you need that one-time boost to push you through. Flu is one of those vaccines that we really continue to struggle with because it needs to be renewed every year. It's an annual boost. So majority of the childhood vaccines, so let me summarize. Majority of the fine childhood vaccines, you don't need adult boosters other than the list that you see here.
Thank you. And another question, I think we have time for a couple more questions, Kathleen, and then I'll turn it back to you. If I had the Pneumovax 23 in 2018, should I get Prevnar 13?
If there's been a 1-year gap and you're eligible, I would say yes. Once you get the Pneumovax, you should wait for a year to get the Prevnar 13.
What if it's more than 1 year? Because 2008, that's 3 years ago.
2018. So yeah, the answer is yes, you can get it because, you know, vaccines is one of those interesting things. The longer the space, the better the boost. Because it's really what vaccines do is they boost your immune system. So once they've encountered an antigen or a disease particle, they're reminded. So the gap gives them a good reminder. So 3 years is still good. You should still get your booster.
And just circling back to the high dose flu, will that be available at the same time on October 12th?
For long-term cares and personal care homes, yes. In Saskatchewan, I would hazard that it might actually be available in the private market now. I'm not really sure. I don't usually check that, but I would check that out because the private market is not, you know, beholden to the dates that are given for the public program. If they have it, they can go ahead and start issuing it. So for those of us who are seniors who live at home, if you can check with your pharmacy, October isn't that far away. So I would try and get it early.
Excellent. Well, I think we've taken up your time now, and we're reaching the top of the hour. I want to thank you, Dr. Opondo, for your wonderful information and explanation on adult vaccinations. I hope that the people that have attended have got the information that they need to make a decision as to whether or not they'll put down the money to get their own vaccination, but also to keep in mind, C.A.R.P has been pressing the provincial government for funding of these vaccinations. So we keep pushing forward with that, with the hope that the provincial government will step forward and realize that it is a benefit. It's a benefit to the government price-wise. It's a benefit to our older adult population. It's a win-win for everyone. So we do want to do that. In addition to that, now, I thanked you. I wanted to mention that the University of Regina Lifelong Learning Center, they are also putting on a free Zoom session, Vaccines in the Older Adult, on October 13th at noon, from noon to 1 o'clock. And if anyone is interested in more information with regards to vaccines, just simply call the University of Regina Student Instructor Services to register for their course. In addition to that, we have C.A.R.P has got a fall prevention session coming up on September 28th. And we encourage you to check that out on our Facebook page and get the link there to join us for that. And one final note, I want to thank you today for participating in our discussion. If you're interested in learning more about C.A.R.P and perhaps getting involved, send us an email to sk@carp.ca. We're looking for people to fill new positions in our board representing the Saskatoon-Humboldt area, as well as the north, central, and southern areas of the province. Drop us a line and let's talk. So in addition to that, I just want to thank you for joining us today, and I look forward to seeing you on future Zooms. Thanks very much. Bye.
Bye, everyone.
Okay, thank you.